Okay, I think we've got everybody here. I'm John Schroeder. Been in and around wound care for a couple of decades and have really enjoyed my interactions over these years with providers, but especially with mobile providers who I think have been targeted ruthlessly lately. And so I wanted to just kind of spend some time going through why we're here and why I want to do these webinars continually and continue to come out with more information on LinkedIn and in separate videos and podcasts and webinars. The core principle that we have at Venture Medical as it relates to mobile wound care is that mobile wound care is a necessary and valid specialty that requires diligence and excellence in execution. There's just no more room for sloppiness or for doing things kind of the best we can. We've got to be very engineered, right? So our role is to support a vigorous community of practices. And to help create that, we want to provide information that we've gathered from subject matter experts all over the place in wound care and start to create conversations. Now, I have a disclaimer that's partially from me, partially from the company. We make no claims that we know everything. And this is not about my knowledge. This is about creating conversations that drive you forward. We seek to make our clients more prepared and continually more productive so that they can grow in the hope that we'll grow with them. We have enjoyed over the years numerous experts that we engage with constantly on everything from reimbursement to clawbacks and audits to software and systems and EMRs and all types of modalities for treatment. We gather information from them to make it available to you in these webinars, and we hope that you'll enjoy number 2, Engineering for Earthquakes. Let's take a look back at last week so we know where we're coming from so we can see where we're going. Last week we talked about building a rock solid foundation, or actually it was a couple weeks ago. And in that, we focused on documentation being the foundation of a good practice. I mean, I think that's patently obvious right now. We want to make ironclad documentation a system, a result of a system, and not dependent upon people. And there's lots of ways we can do that. And AI is really coming up in that arena very quickly. We want to diversify procedures that we engage in with our patients, not just for diversity's sake, but because we think that there are some things that are just more appropriate from a patient care perspective and driving them to healing, as well as the financial realities of keeping the lights on in our practice. And we think there's a significant overlap there. And then we talk about blooming where you're planted. That started with SAWC. We had a bunch of flowers because it was spring, and I came up with something that my mother told me a long time ago, which is like, you are where you are, and you're right where you're supposed to be, so just bloom where you're planted. And that kind of tumbled through my head for a long time, but as it relates to mobile wound care, I think a lot of folks were trying to expand well outside of their comfort zones and well outside of their where they're the subject matter experts, like maybe in new communities where they didn't understand some things. And I think we've really gone a long way to getting people to focus on areas where you are strong and starting there. So what is engineering for earthquakes? In a nutshell, what we're trying to do is create a system for everything that absorbs change seamlessly. We need to create mechanisms to build practices that absorb disruptions, changes in reimbursement, et cetera, rather than reacting to those things. And so we're going to focus today on 3 areas, although there are many. Patient acquisition. Where are you getting patients? How closely are they to you? How appropriate are they for your level of care? Revenue per patient. This is sort of a lifetime quest. It's not something you do overnight in today's environment, but making little tweaks to make sure that we're actually spending more of our time on patients that actually can drive revenue as well, so we can continue to practice, and making sure that our average visit value continues to rise. And then efficiency per provider. There's lots of things we can do ourselves. I think as practice owners and founders, people get very, very good at being efficient. but how do you create systems that drive that efficiency to other providers within our practice? We all know we need more providers in order to grow our scope and our practice. How do we leverage systems to make sure that everyone's doing things the right way, the same way, the most efficient way? So we'll start first with patient acquisition. Obviously, we need to localize our patient flow. The days of driving a couple of hours or even an hour to see one patient are probably over. They left at the end of the time when healing certain wounds would cost more than several years of dialysis. Obviously, the market was skewed at that point. Today, it's not. So you need high volume facilities, but do you really want all of them, or are there ones that are better than others? We're going to try to find out. Multiple consistent patient pipelines that overlap and intersect. We want to get into the referral network business, not just the referral business. The days of having a marketer going around and trying to find patients at home health agencies one at a time are over. We need to design systems that bring patients to you because you're involved in a network that is important and whole in your community. Localizing your patient flow. Obviously, it's not just proximity to the provider or to you, but it's building networks that are next to each other or near each other. And at the same time, trying to minimize low or non-reimbursed time. So reducing drive time, reducing charting time after the visit, making sure that we're not just going to a home health visit where all that's needed is a vac change, something like that. And then maximizing the amount of patients seen. Obviously, reducing drive time is part of it, but how do you focus on average encounter value when you're in facilities? How do you make sure that you're seeing the right patients and that you're in the right facilities, or that you're working with the right home health agencies? So instead of creating several points that provide patients to us, which can kind of create multiple points of failure, or maybe give us a patient flow until they realize that we can't take Humana, for example, and then they shut off. We really think that you've got to find folks that are already referring to each other and get them convinced to be in their network. So you can start at the hospital with the discharge planners. 6 Subway sandwiches goes a long way towards getting these folks to understand the value you create. And if you bring them the right message, you may be able to find out, where they're sending patients that need a short stay, a rehab stay, or a skilled nursing facility for a long stay, or a home health agency. At the home health agencies, there's a lot of folks out there now who are running home health agencies who don't have anyone to certify care plans when they receive the patients. Is there a way we can step into the middle of that and say the quiet part out loud up front? We're not going to be able to take every single one of their patients and visit them every week. Patients where it's really moisture management, or there really isn't a lot to do. There's something's healing, or it's on the way to closure. That patient may not need us to be there every week, but we'll certainly certify a care plan and be a resource to them, and also just loosely follow the progress of that patient. And if we do need to jump in at some point, go ahead and do that. And finally, the skilled nursing facilities. There's definitely an opportunity to improve patient care and satisfaction in the nursing home of the patients who have wounds. But how many of those patients are Part A versus Part B? And what can we do with those patients that are Part A? And how many of those are Med Advantage? And is that building under a lot of pressure because they've already had an F-tag that's wound related? And are they going to give you the clinical flexibility and freedom to do what needs to be done to call a stage 3 a stage 3, for example, rather than try to downcode it to a stage 2? Revenue per patient. So we talked a little bit about this, and we need to scale the lifetime value of our interactions, right? So, of our patients. The patients we do treat, the ones that fall into our practice might be they're optimally suited for an advanced therapy, and they need that therapy because otherwise they'll stall or go backwards. That's a big part of it, but there are other parts to it as well. Diversify reimbursement treatment pathways. So it's not just about different procedures we can do, different diagnostics. It's also about how are we actually coding for visits and how are we monitoring patient progress? How are we setting metrics within our practice to flag us? And how are we having somebody review those patients that are non-standard, they're not going in the right direction, and get our providers completely informed and ready to do something different with them? So this will be a much deeper dive in a future conversation, but what are you doing with each patient? When you're seeing them if you're not, even if you're just in a standard of care period, are you billing an E&M, CPT, both? Are you just trying to do a debridement and build a CPT? Are you not feeling like you're able to add an E&M code to that? If you are able to add an E&M code, or you're just doing an E&M code because they're not indicated for debridement at that time, are you using MDM or are you doing time-based coding? And how do you determine which one you're using? And are you doing one or the other, or are you making a decision on each case? And are you taking all the factors into consideration, like all the time you spend before midnight that day after the encounter on arranging things for that patient, making sure they get what they need from, say, another provider or therapist? And that kind of flows into chronic care management codes, PCM, CCM, and then longitudinal based care. All of those are add-ons that we can increase the value of what we're doing during the standard of care period of treating that patient, or in patients that really aren't indicated for any kind of advanced therapy, or in addition to those advanced therapies. So there's a whole lot of stuff here. I think we probably got 8 or 9 slides of content just on this one, but that deep dive will be the focus of, will be part of the focus of next webinar we do. So just in diversifying the reimbursement pathways, like we talked about, chronic care management, sometimes if you're going into a nursing home, the PCP that oversees a building will be doing that. We think there's an opportunity to have a discussion about letting you, if they want you to be the physician on service for that patient, for their wound primarily. We think that there's so many things that go into the wounds that you should be able to take that over. And if that's not the case, then what about a principal care management code for their principal chronic condition? Advanced therapy mix. There's just a lot of things we can do now, like we talked about before. But when are you doing them, and how are you systematizing which one to choose and when? And how are you making sure that it's not a human making decision that can fall behind because they get busy, but at every point where, say, the trend line of positivity is broken or somebody becomes stalled, that we're actually considering the right advanced therapy, and we're already prepared for that, because a couple weeks ago, for example, we submitted a prior auth, and we know that it's approved if that's part of that process. And then how do we appropriately combine E&M codes and CPT codes? Some people will say there's never an opportunity to do that. Some people say their taxonomy prohibits that. If you're listed as a traveling surgical group, then maybe that's true. There's a whole lot of other taxonomies that don't make that true. And we see people do it all the time. And we're going to bring in experts to talk about avoiding audit red flags. For maybe we don't want to do this on every visit, but you're certainly managing a lot of things for the patient. And so it lends itself well to, in the case when you do need to do a debridement, that you also are spending some time in an E&M code type of milieu. So we're going to work through that. One of the last and most difficult things to do is efficiency per provider. Working for years, as I have, with a bunch of different mobile wound care groups, constantly I hear from the founder or the clinical lead that if I could just get all my providers to do things the same way, or I don't know why they'd have to chart when they get home, they should just do it before they leave the building, or I can't understand how they can't get their paperwork done, or I don't understand why they're not requesting a graft through our system because everybody else can and they can't. And so I really think that there's an opportunity to systematize efficiency and create a system that helps them be more efficient without them putting more effort into going outside of their comfort zone. These are all individual practitioners that want to do the best thing, But if we have a standard of clinical decision making, otherwise known as a clinical practice guidelines, I think that there's a way to help each provider become more efficient. We're going to start saying the quiet part out loud here as well. A lot of times when we go into buildings, there are these unspoken expectations that they have of us, that we'll wait here, we'll go see that there. Oh, and by the way, can you take a look at this patient? Not really as a formal visit, that we've got to be able to find ways around. So how do we do that? I kind of like to call this one the facility speed system. Staff's got to be engaged as a team member for your provider when they go into a facility, right? We've got to know at least the identifiers of the entire census, especially the new ones that, they need to hand us a list if we don't have it already through our back end system of who we're going to see that day. It's kind of like a meeting before the meeting. When you get to that building, you find which nurses are going to round with you that day. And you basically know all the patients you're going to see. The provider will have all the things they need for those procedures. Like this is for this patient on this date of service. The patient should always be prepped and in the room, meaning that their dressing is off and that they're not like wheeling around or at a breakfast. So there's some scheduling challenges there, but there's also just some standards that you've got to set up front with the operator. And any kind of stat referrals, if you don't have an EMR integration with that facility, need to go to your home office so that they can actually enter the chart note into your EMR before you get there. And then reducing low value time. Virtually every time I round in a building with a provider, and we're trying to get through a lot of patients, sometimes 60, 70 a day at a couple of buildings, there's a nurse that says, hey, I'd really like you to take a look at this. Or can you just check on Susie Smith's healed wound or all that? Part of creating the team is getting them to understand that part of your job is to help them know when to ask you to see a patient or take a look at something or not. You can't do that without really comprehensive education that a lot of the buildings may provide, but when your provider gives it, they kind of tend to listen more because they want to think that they're getting knowledge that other people don't have. Things like deep tissue injuries, like how can we screen for those and the incumbent pressure injuries that might result from that. MASD, cellulitis versus, other types of fungal, irritation, right? Those are in-services we can do, and we can actually drive a lot of those questions back to themselves, like that they won't need to ask those questions. And then we need to just set those standards for those low value visits like we've been talking about, which is just make sure that the patients you're able to see are really the ones that are going to need your help the most. How are we going to engage with folks during the EDS period? Because obviously if a patient's being recently acquired by a nursing home in that first 5 days, they're trying to set the standard for, how they should be paid for that patient based on their acuity. And is there something you can add value in there? And should you be able to bill a facility for that? Because you're probably not going to be able to bill Medicare for that. Who will assess these wound stalls, right, in the building and make sure that your provider is aware that something needs to be changed? Who's going to provide that information? Those are all ways to set standards for the lower value visits that, sometimes we do them, but you end up netting out next to nothing. There's got to be ways that we can mitigate that. Okay, key takeaways today. We want to build a resilient patient acquisition engine that isn't dependent upon personalities or marketing people. And I've always thought it's funny when mobile wound care providers talk about their marketer. They're not marketers, because if we had good marketing, we wouldn't need them at all. And what I mean by that is if you create a story brand and an image for that brand and marketing materials that go out to people, you may have a salesperson covering all your areas, but essentially marketing is something that I think is lacking in mobile wound care providers mostly. Now, there are some great examples out there, right? But that's another thing that talk about on a future day. How do we create a resilient patient acquisition engine when you're involved in the referral pathway that usually involves a discharge planner who knows somebody at a nursing home, who knows a home health agency? How do you get into that network without needing to go pull individual patients through a compensated salesperson? How do you maximize revenue per patient through smarter billing? There's a lot of folks that have a great level of expertise. There's also a lot of disagreement here, but we're going to go deeper into E&M versus CPT, time versus complexity billing, and then the add-on codes. That's going to be a focus of an entire webinar, and I hope we'll get some satiety for that. And then how do we engineer provider efficiency to absorb disruption? Rather than reacting to disruptions, what are things that we can do at the practice ownership level to make sure our providers are more efficient and more effective in what they do? Those are the key takeaways today. I hope that you enjoyed this. And now I really think we want to open it up for your discussion and questions. Let's see. Okay, we got a very quiet group today. We're not hearing any questions. You can put them in the chat or the Q&A.
Yeah, John, I think the Q&A, which is in that top right corner, is probably the easiest place for people to put it.
Okay, I'll give it a couple more seconds. I guess there is a question. All right, we have a question from Petra. I hope I'm pronouncing that correctly. Who asks, how have the changes in the marketplace since the 2026 reimbursement changes affected the buildings and patients? Boy, that's a good question. That's a loaded question. So all of you know I've been very politically involved for years, and I'm just going to start with the broad to go to the specifics, so bear with me for a moment. We all at once have the head of Health and Human Services going around and talking about this victory lap that they are taking continually, that skin substitutes utilization has been reduced 99%, and that they have taken 24 trillion or something like that. Maybe it's billion. I think it's billion. Can't keep track of these government numbers anymore. It's 24 billion out of wasteful spending. That's the backdrop that we're operating in. So at the facility level, what we're seeing is a lot of reluctance on the mobile wound care provider groups to use any skin substitutes, really kind of overthinking when it's appropriate or not. You know, IVR gets approved, they might have a coding person review the notes, and you know, to the prior authorizer at the insurance company or to the IVR supplier, it looks like the notes are in order. We even have an AI tool that can review their notes that works the same way their Wiser tool uses at the government level. So we know information that's inputted, but people are still not using skin substitutes. So what's happening is, as recently as last week, we're hearing from patients saying, I just want to go home. Why can't I get my graft? It was going so well. So that might be an anecdotal example, but I suspect strongly, even hearing from some of the largest mobile groups out there, that their utilization of skin subs is way down. The impact that that's having on patients, I think we're just starting to see it now. So we had another question that says, will you discuss the hows? You know what? I think in this format where we're trying to get, through a webinar in 30 to 40 minutes, what we really want to do is engage directly with folks who have, there's probably a large part of what we talked about that you probably already know. And so, but maybe there's a part of this presentation that you want to hear a lot more about. And so I've been making myself available for one-on-one conversations. We have a whole team here that engages in figuring out the how of everything that we've talked at a broad level on. I just don't think that there's enough time constraint, like basically one slide here. If we unpack the how, could take up an hour. But we're certainly willing to engage with you to discuss that. And like I said, we're committed to helping. So I think that's kind of what we want to know is exactly what you want to focus on, and then we'll give you all the hows that we know, and we'll point you to more resources and references as well. I got another one from Petra. What other options for patients in facilities are there? So currently, there is a positive change on low frequency, non-contact, non-thermal ultrasound, otherwise known as ultramist. It is not a debridement. It is ultrasonic therapy. And we need to make sure that it doesn't appear on our nose that way. That has now become kind of a sometimes therapy in the buildings, meaning that it's clearly been a change in 2026 that should be allowed. Previously, it was more of a PT initiated therapy in the building and only really available in the home. So that's a positive change that's new for patients, and we have seen some good efficacy for that. We have data on PRP that figuring out a way to get it into a published study is the next step, where there were a lot of patients treated with pressure ulcers in a nursing home. Those are both no-nos for PRP right now. But there is a large body of data of patients in Places Service 32 who all had pressure ulcers that did extremely well with PRP. I don't have an answer on when that's going to happen. We're pressing on trying to get that published, and we'll update you when we know more. Other than that, there are other options for patients like collagen under the DME benefit. There's always been a place for collagen for certain types of wounds. That's an area that can be overutilized as well, though. And it's also an area that you have to be licensed to have a DME, and you have to be licensed in that state, and you have to line up the chart notes with the actual CMN for that DME. Somebody has to bill for it. So we think that's an area that's going to be helpful to patients. And I'm answering another question as we go from Mark. But I don't think that straight up collagen is going to replace skin subs. We haven't seen as great of efficacy as consistently with collagen as we do with skin substitutes, especially amniotics, and our keratin-based skin substitute, Progenimatrix. Okay, so if you've heard something in here that makes you want to learn more and discuss the how we do these things, you can certainly contact us. We'd be happy to help. You can send that email to write to me if you want, john@venturemedical1.com, and we'll get back to you right away with an introductory call and learn more about you and see how we can help you further. If there aren't any more questions, oh wait, another one. Valeria says practices are facing a growing wave of recoupments and financial pressure. Many are barely surviving, and some are being forced to close because they cannot withstand aggressive actions from skin graft vendors, including lawsuits and repayment demands. What can mobile wound care providers expect in the future? if practices are facing recoupments and financial pressure, I think the largest part of that is how do we deal with the recoupments and financial pressure? Um, Folks that have sold those practices skin substitutes and done their due diligence and helped those practices all the way through the ALJ, I don't think should be initiating lawsuits. Now, if the practice just walks away from a skin substitute company, nothing can be helped in that situation. But I think that in the future, what we're going to see is fewer recruitments. Now, that's arguable, right? But the money's gone. The money has gone away. And there are other things cropping up that seem to be rapidly or exponentially growing. Like I read something this morning about PCR for UTIs has expanded like tenfold in 2 years. The government seems to kind of go play whack-a-mole. I don't think that their goal, as many of us are seeing, is to actually heal patients. It's actually to cut costs first, and hopefully we can heal them while we're cutting costs. So I don't know about the aggressive actions we're talking about. I think that every business should try to recover revenue, but all of us at Venture want to support people through anything we can do to help them win and succeed all the way to and past an ALJ hearing. And we've had a pretty good track record of getting people through that. If you don't want to take on that fight, it's pretty hard to help you. But we also know that if you don't take on a small action where you're being recouped unnecessarily or illegitimately, they're just going to come at you with another one. So we've got lots of partners that help us with that across the nation, from lawyers to expert witnesses who are very effective at helping you fight recruitments. Okay, let's see if I'm seeing any more. Being asked to repeat my answer to Mark's question. Mark asks, do you see collagen as a new growing product to help replace skin substitutes? And my answer to that was, collagen is another available tool in our toolbox, but it's a little different than a skin substitute, where a skin substitute is billable by the provider and separately payable under the physician fee schedule. The collagen is under the DME schedule, so it kind of goes under the surgical dressings category of DME, which is everything involved. Any kind of dressing, the patients have a benefit under their DME benefit to cover that. So I don't see that as a real commercial opportunity for everybody there. Nor do I see it as an opportunity for us to replace the efficacy we've seen with especially amniotic or even keratin-based skin substitutes, but it is a helpful tool. I think that there's also some danger of overutilization in collagen as well, and there are very common TPE audits among DME providers, making sure that chart notes match the care plan, and then especially in the buildings, does your care plan in the building match what the care plan of the mobile provider has? And does that all comport with, and do the chart notes comport with why you've chosen collagen? There's also certain sizes of collagen. When a wound gets really big and you try to put a big collagen on there, a lot of people won't even try to build a larger collagen coat anymore because they get denied every single time. So I don't know that collagen from a reimbursement milieu or from an efficacy standpoint will ever replace our skin substitutes. They're just another tool in the toolbox that we're excited to have access to, and we can help with that in our DME. But there's some caveats to that, and I don't think that they bring the same level of attack to the stalled wound that, say, an amniotic skin sub like our Vendage AC or even our Progena Matrix can bring. Okay, well, I want to say thank you very much for everybody who's been in attendance, and you can always reach out to me directly if you'd like. It's just john@venturemedical1.com. And if you want to schedule some time for further discussion, I'd be happy to engage in that. So I appreciate your time today, and hopefully this was valuable to you.